Sameshwar Garu, we are live now.
Okay, thank you, Savan. Ma'am, with your permission, shall I start?
Yes, please.
Yeah, thank you, ma'am. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the participants to post their questions in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. Ritu Santwani ma'am. She has been a very good supporter of our Shield and she's very kind-hearted person, I can say. And we are very privileged and glad to have you, ma'am, for today's webinar. And she's a obstetrician and cosmetic gynecologist. Sorry. She's an obstetrician and cosmetic gynecologist and IVF specialist. And she's an honorary professor at Ops and Gynecology at WIMS Medical College. And she has 20 years of veteran of obstetrics and gynecology services and specialized in cosmetic gynecology and test tube baby in each and every aspect of infertility and provide comprehensive services in IUI, IVF, and assisted hatching, egg donation, embryo donation, surrogate motherhood, and male infertility. Also, natural fertility treatments, semen banking, embryo freezing, sexual and psychological problems, along with the cosmetic gynecology treatments, PRP therapy, and try to give moral and emotional support to the infertility patients. And she's an excellent social and interpersonal communication skill person to interact with the patients and hospital staff, and she has a strong ability to work under extreme pressure during the handling critical cases. And she completed her medicine from GSVM Medical College and MD in Ops and Gynec from King George Medical College. She completed her FICOG ART from NUHS Singapore, and she is a postgraduate diploma in clinical cosmetology and medical cosmetology and RCOG associate and reproductive genetics, and also completed FOXY Justosis certified and also Indian Academy of Ops and Gynecology honorary fellow for improvement of women's health. And coming to the career highlights, she connected.
That's okay, Dr. Sameshwar.
No, anything saying is not enough, ma'am, regarding you.
That's okay. That's okay. Yeah.
So thank you, everyone. And the present webinar is streamed through Shield Connect, which is a digital platform of Shield. So if you miss any part of this program, it will be available in the Shield Connect. And also, if you want to see Dr. Ritu Santwani's earlier webinars, past webinars, also will be presented in this web page. And with this, I request all the delegates, please do visit Shield Connect webpage. And coming to today's topic, as we know, the GDM for at least a generation, there has been a divergence opinions about the gestational diabetes mellitus. So whether GDM problem solved or still it's a Pandora box. So now, without wasting much time, let me turn over the time to Dr. Ritu Santwani, ma'am, to talk on GDM and its recent developments. Over to you, ma'am.
Yeah. Thank you, Dr. Sameshwar, and thank you, Shield Connect, for inviting me. And I want to congratulate also the Shield Connect, because just now, I think few days back only, they received a big award for doing an excellent work in the field of this. So now, without wasting time, I'm switching over to today's topic. And I want to welcome all of my dear friends who have joined all across the geography. Making it full screen. So a very good evening to everyone. So friends, as we all know, we have just gone through 2 bad phases of the corona, and my every presentation will start with Stuti to Ma Durga with these 2 lines. या देवी सर्वभूतेषु चिकित्सा रूपेण संस्थिता नमस्तस्यै 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 नमो नमः. So before I switched over towards today's topic, because as we all know that September month is a PCOS awareness month. So my two sessions, upcoming sessions, one is on the 10th September with the pregnancy in PCOS, and another on 17th September is the PCOS and nutrition. So do join, friends. I will post the links on the social media. Besides that, I am conducting the online master classes on aesthetic gynecology on 19th September, which will be endorsed by ASFMS ma'am and the World Society of Cosmetic Gynecology. Details I have already posted. Another is whosoever is interested for this masterclass of sexual medicine that we are organizing on 8th and 9th October. So all the details I have posted. So those who are interested are welcome to join in that. So now coming to the today's topic, a very, very interesting topic that, and we all are having a lot of confusions for the treatment of this. So this is a very good topic to clear our dilemmas. The recent development on the gestational diabetes mellitus. So friends, as we are aware that what is this gestational diabetes? So as we know, it is one of the most common medical complications of pregnancy. Affects mother, fetus, and outcome of pregnancy. Hence, early detection is very necessary. Defined as impaired glucose intolerance with the onset or first recognition during pregnancy. Undiagnosed or inadequately treated GDM can lead to significant maternal and fetal complications. Women with GDM and their offspring are at an increased risk of developing type 2 diabetes in the later life. So now, what's the prevalence of GDM? It is globally 1 in 10 pregnancies is associated with diabetes, 90% of which are GDM. The prevalence varies worldwide and among the racial and ethnic groups. Prevalence rates are higher in Black, Hispanic, Native American, Asian women than in white women. The prevalence of gestational diabetes has been reported from 3.8 to 17.9% in different parts of India. Most of the presentation is based on the studies what we are getting in the India and Asia. Asians and moreover the Indians are at a greater risk of diabetes mellitus, and hence the pregnant women are at a higher risk of gestational diabetes. GDM is associated with an increased risk of maternal and fetal short-term and long-term ill health. So here is the chart. This is from the very recent studies. The article is showing that what's the prevalence of the GDM in India. So here we can see amongst the different states, and amongst the Lucknow, it has been reported 41, in the Punjab 35, it is on the percentage basis. In the Tamil Nadu 18.9, and least in the Kashmir is 3.8%. So still the incidence is very, very high. So so now what are the guidelines? Whole of the today's presentation is based on the recent guidelines has been given by the FOXI in 2021. So this guideline suggests the GDM is defined as a carbohydrate intolerance resulting in hyperglycemia of variable severity with the onset of or first recognition during pregnancy. GDM is defined in this way includes the woman with undiagnosed pre-existing diabetes as well as women with first onset hyperglycemia during pregnancy. In the past, less severe GDM was referred to as impaired glucose intolerance and the more severe as GDM. But now, the whole end of the glucose spectrum and more simply referred as a GDM. FIGO recommends the term the hyperglycemia in pregnancy. Whether the diabetes is before pregnancy, during pregnancy, or diabetes is because of the pregnancy. So friends, according to FIGO guidelines, we have to use the terminology, the hyperglycemia in pregnancy. So As we all know that what are the short-term and long-term complications of mother and offspring due to GDM? So in the mother, as we know, in the pregnancy, the chances of preeclampsia are high. While once the lady go in the labor, the induction of labor, cesarean section, operative deliveries, labor complications, all increases. While in the postpartum and beyond, once the lady has suffered from gestational diabetes, the chances of recurrent gestational diabetes also increases, and the type 2 diabetes also increases. While in the offspring, the congenital anomalies, as we all know, the congenital heart defects, caudal regression syndrome are very, very important. So the CNS, cardiac, fetal programming among this large for gestational age, macrosomia and increase in the fat mass has been reported. Among the neonatal complications, the prematurity, the perinatal asphyxia, respiratory distress, metabolic complications, hypoglycemia and hypocalcemia, polycythemia and hyperviscosity, low iron stores, hyperbilirubinemia, cardiomyopathy has been reported, while among this long-term outcome, the obesity, the type 1 diabetes, type 2 diabetes, and metabolic syndrome has been reported. So now what are the consequences if the GDM not diagnosed and not treated? So what are the reviews regarding this? So the maternal, fetal, and neonatal, we will take one by one. So as we have just discussed, amongst the maternal, the preeclampsia, the infections, lacerations, cesarean delivery. While in the fetal, the growth abnormalities, polyheteronios, and as we all know, the chances of the sudden fetal demise are also high. While in neonatal, the birth injuries, hypoglycemia, seizures, polycythemia, electrolyte imbalance, hypocalcemia, hypomagnesemia, hyperbilirubinemia, and respiratory distress. Identification of GDM, screening and testing. So again, this all has been from the recent guidelines from the Endocrinology Committee of the FOXI. So the screening or diagnostic kit test is any approach used to gather the clinical information for the purpose of making a clinical decision, and is a process that helps to determine the presence or absence of a condition. So for the GDM, the oral glucose tolerance test is generally the diagnostic test of the choice, and the test is usually administered at the first antenatal visit between the 24 and 28 weeks of gestation. Yeah. Just a second here. And a plasma blood sample is obtained following an overnight fast, and then a 75 gram or 100 gram of glucose load is given, and further plasma blood sample is obtained after 1, 2, or 3 hours. GDM is diagnosed depending on the criteria used if 1, 2, or more glucose levels are equal or exceeded. So friends, as we have just gone from this, that OGTT between the 24 and 28 weeks of gestation. Yeah. Just, yeah. So, according to this ACOG and UK, the National Institute for Health and Care Excellence, the NICE guidelines recommend that the women who have had the GDM in the previous pregnancy should be offered diagnostic testing. According to this, American College of Obstetrician and Gynecology also recommends the early testing in obese women or women with impaired glucose metabolism as early as possible to identify the undiagnosed type 2 diabetes. While according to the Australian Society, that recommends the risk factor assessment in early pregnancy, and risk factors are ranked by the severity, and either 1 high risk factor or 2 moderate high risk factors are needed before an OGTT offered. So friends, here what the protocol we follow in our practice as soon whenever the pregnant patient approaches. So definitely we recommend for the 1 blood sugar testing, because sometimes the patients won't come properly in the follow-up. If we are waiting for the 24 weeks and 28 weeks that we are going to do at that time, sometimes the patient suddenly disappear, again they come directly at 32 weeks. So in our practice, definitely I recommend the blood sugar whenever the pregnant patient approaches you. So what are the proposed guidelines for screening for GDM in India? The universal screening at the first booking, the first trimester. So among this, if the fasting blood sugar is less than 92, then patient is non-GDM. Then single step OGTT can be done with 75 gram glucose in the fasting state at 24 to 28 weeks. If you find the fasting glucose 92 to 125, then GDM. If fasting is more than 126, then of course we have to recommend for HbA1c. If it is more than 6.5%, then it is over diabetes. While for this non-GDM patients, the criteria will be for this, the fasting 92, 1 hour 180 and 2 hour 153. If any of the one abnormal value, then GDM. If all the values are normal, then non-GDM. While in the case of the high risk, we have to repeat the GTT at 32 weeks. So friends, what the guidelines we are following in India, I am sharing with that. Yeah, I am able to see the greetings from Dr. Bashir. Dr. Bashir has joined all the way from the Somalia. So Dr. Bashir, later on, I want to know what the guidelines you are following in your country in Africa. My today's presentation is based on from the what are the guidelines we are using here. This I have just discussed. So now what are the protocols for investigation? So the testing for GDM is recommended twice during the ANC. The first testing should be done at the first antenatal contact as early as possible in pregnancy. The second testing should be done during 24 to 28 weeks pregnancy. It is important to ensure the second test, as many pregnant patients may develop blood sugar intolerance during this period, 24 to 28 weeks. So it is very, very important, even though we have done the first blood sugar and that is coming normal, even though once the patient is coming us to the proper follow-up, we have to repeat this blood sugar in between the 24 to 28 weeks. So moreover, the 1/3 of GDM positive women are detected during first trimester. There should be at least 4 weeks gap between the two tests. The test to be conducted for all pregnant women if she comes in late pregnancy for ANC at the time of the first contact. If the patient presents beyond 28 weeks of pregnancy, only if patient is approaching us beyond 28 weeks, then also we have to go for this blood sugar testing. So, yeah. Thank you. So now, what are the methodology tests we are using for the diagnosis for the DIPSI method? So friends, again, these are the guidelines from the FOXI, the single step testing using 75 gram oral glucose and measuring the sugars 2 hours after the ingestion. 75 gram glucose to be given orally after dissolving in approximately 300 ml water. Whether the pregnant lady comes in fasting and non-fasting state, irrespective of the last meal, the intake of the solution has to be completed within 5 to 10 minutes. A plasma sterilization glucometer should be used to evaluate the blood sugar 2 hours after the oral glucose load. If the vomiting occurs within the 30 minutes of oral glucose intake, the test has to be repeated the next day or else refer to a facility. If the vomiting occurs after 30 minutes and the test continues, the threshold of the blood sugar level of more than 140 mg per dl. Sorry. Just a second. Or equal to more than or equal to 140 has been taken up as a diagnosis for the GDM. Dr. Someshwar, I am getting message from some of my doctors from the Bangladesh that they are trying to join, but they are not able to connect.
Okay, ma'am. I mean, from the delegate link, ma'am.
From the delegate link, that is actually Bangladesh Society President Dr. Sheikh Jeenat is, she has dropped me around 5-6 messages. Huh?
Okay, okay, ma'am.
Can
hello?
I share you the number? Will you help her, please?
Yes, yes, ma'am. Sure, sure.
Yeah, yeah. Meanwhile, I'm able to see my so many friends are joined from this Iran also. And yeah, hello, Dr. Vijay. And big hi to Dr. Khalida. I'm able to see her also. Yeah, Dr. Sumeshwar, I'm just... Friends, just a second, because so many friends are not able to join. So that's why I'm... Yeah. So I hope this is clear for everyone. So universal testing for GDM. So what is the universal testing for GDM? For the pregnant woman, testing for GDM, the first antenatal visit with 75 gram glucose, oral glucose and 2 hours blood sugar. So as we have seen, friends, the positive if more than 140 mg per dl, managed as GDM as per guidelines, negative if 2 hours blood sugar less than 140 mg per dl, repeated testing at 24 to 28 weeks, positive if 2 hours of blood sugar more than 140 mg per dl, managed as GDM per guidelines, negative if the blood sugar after 2 hours is less than 140. So these are the guidelines what we are following. So friends, now what are the screening tests? Now some have brought me the question that ma'am, 75 gram glucose is very easily available. There are so many companies are marketing. The preparation is coming of 75 gram glucose. Yes, one practical problem. Yes, sometimes the patient says, ma'am, अगर हम इतना सारा blood sugar एक साथ लेंगे, glucose लेते हैं, तो हमें कभी-कभी vomiting sensation होता है. So but usual tip what I follow in my practice, we are giving the 75 gram sugar with 300 ml water. In that we are squeezing some little bit of lemon also, so the taste will also comes good and the report is all, and patient can easily take also. So now what are the approaches? The single step approach and the two-step approach. The two approaches for diagnosing the gestational diabetes mellitus. So according to this ACE and ADA guidelines, the one step 75 gram 2-hour oral glucose tolerance test, and according to ACOG guidelines, the 2 steps a 50 gram 1 hour oral glucose challenge test followed by a 100 gram 3 hours OGTT if necessary. Now in the single step approach, here the patient is given 75 gram of oral glucose without prior 50 gram glucose challenge test. The test should be performed in the morning after an overnight fast of at least 8 hours but for more than 14 hours, and after at least 3 days of unrestricted diet and physical activity. Fasting and 2 hours values are estimated. So friends, this is very, very important. The test should be performed in the morning after an overnight fasting of at least 8 hours, but not more than 14 hours, and after at least 3 days of unrestricted diet. Otherwise, what happens whenever we tell the patient themselves from 3-4 days stop eating the sugars. So these instructions are very important to give the patients. So now, what is the two-step approach? In this, the recommended two-step approach begins with either universal or risk-based selective screening using a 50 gram 50 gram 50 and 1 hour oral glucose challenge test. Among this screening test are diagnostic 100, a 3-hour oral glucose tolerance test if the screening results meet or exceed predetermined the plasma glucose concentration. So friends, better we will remember of the 75 gram what we are following in India. So this will again create a lot of confusion otherwise. So for this OGTT test, now what the guidelines have suggested by this 1 step and 2 step, we have to follow, we are following the 1 step with 75 gram OGTT. In this fasting, 92, 1 hour 180 and 2 hours 153 mg per DL. So we will focus on of this 75. So from the threshold values for diagnosing this GDM, we have just seen the fasting 92, 1 hour 180 and 2 hour 150. We have to follow whenever we are sending, we have to see the reports whether it is coming in milligram per DL or it is coming on millimole per liter. So one or more of these values from a 75 gram of OGTT must be equal or exceed for the diagnosis of GDM. So this is from Professor Shishya et al. Elucidated a test procedure that would not require a woman to be in the fasting state to diagnose GDM. The outcome of this study, the 2-hour plasma levels 140 mg per DL with 75 gram glucose administered to a pregnant woman in the fasting or a non-fasting state. Without regard to the time of the last meal, was able to identify the woman with GDM. Diagnosis of GDM with 2-hour plasma glucose levels more than 140 mg per DL and treatment is worthwhile with a decreased macrosomia rate, fewer emergency cesarean sections, and serious perinatal morbidity may also improve the woman's health related quality life. So, yeah. So what are the advantages of the single test procedure? The pregnant woman need not to be fasting, a very important thing. It causes the least disturbance in pregnant women's routine activities. It serves as both screening and diagnostic procedure. It is extremely useful for diagnosing GDM in the present context of the COVID-19 pandemic. Laboratory glucose measurement is often not available and the testing with a portable plasma glucose standardization glucometer is the only option. RCTs have shown the benefit of treating the GDM woman identified primarily by the post-load values. And again, very important, the fasting glucose measurement is insufficient, which is reliably ruling out the GDM. So, what are the guidelines have come from the FOXI by this March 2021? So, the guiding principles are that all the pregnant women who test positive for GDM for the first time should be started this medical nutrition therapy and physical exercise for 2 weeks. This medical nutrition therapy, MNT, is very, very important. So, most of the patients, because where I am practicing in Pune, I am getting all the patients are the tech savvy and Google savvy. I had given one patient to go for this blood sugar testing. Patient is of 27 weeks. Earlier, her sugar was done at 16 weeks when she approached me. So the reports are normal. Now on 27th week, the patient's test a little towards the higher side. So patient herself dropped me a message on the WhatsApp, ma'am, please start with me the first the MNT, and still if it is not controlling, then we will switch over towards the drug. So yes, the MNT is very, very important. So the woman should walk or exercise for 30 minutes a day. And after 2 weeks of MNT and physical exercise, the 2 hours post-meal sugar also has to be done. Thus, GDM is managed initially with MNT and physical exercise. And if it is not controlled with MNT, then MNT is basically mostly the medical nutrition therapy, the lifestyle changes. Then metformin or insulin therapy is added to the MNT. If 2 hours PPBS is less than 120 mg per DL, the repeat test every month during the second and third trimester. More follow-up tests can be done as recommended by the treating physician. If the 2-hour PPBS is more than 120 mg per DL, the medical management has to be started as per the guidelines. So, among this medical nutrition therapy, MNT, it is very, very important. The principles of MNT therapy is healthy eating during the pregnancy. So, the patients who are diagnosed with GDM, the MNT should be started as soon as possible. The MNT for GDM primarily involves as a carbohydrate controlled balanced meal plan, which promotes the optimal nutrition for maternal and fetal health, adequate energy for appropriate gestational weight gain achievement, and the maintenance of normoglycemia. Diet should be balanced. The carbohydrates 50 to 60% and proteins 20 to 25%. Among this, fat is 25%. So what are the guidelines have suggested? The hypocaloric diets. As per Indian ICMR guidelines, an average weight gain is 10 to 12 kg and addition of 350 kilocalories above the adult requirement is recommended during the second and third trimester. And severe caloric restriction is not recommended as it may result in ketonemia and ketonuria and impaired physical and mental development in the offspring. So friends, as I have just discussed, this is all of the new guidelines. This management of pregnant women with GDM, the pregnant women GDM with medical nutrition therapy and physical exercise. And after 2 weeks, we have to see the, after 2 hours, the blood sugar. If it is less than 120 mg per dl, when we have to continue this MNT and physical exercise, we have to monitor this 2-hourly PPVS as per high-risk pregnancy protocol and recommended by the, we have to, as I always mention in my presentations, if we are treating some of the hormonal disorders, some of the metabolic disorders, or it is always much better that we should involve all the specialties. We as a gynecologist, of course, treating, we do involve the endocrinologist and physician too, or the diabetologist too. In this 2-hour PPBS, if it is more than 120 mg per dl, then we have to start the oral anti-diabetic therapy, either metformin or insulin. Then in that case, we have to monitor the fasting and postparental blood sugar after every 3rd day, or more frequently the insulin, or the bi-weekly metformin dose. So in my practice, I usually, if the patient comes with the gestational diabetes, though I start the treatment, but of course I take one opinion from the diabetologist for regarding the dose schedule maintenance for this, the insulin. So the medical management, the oral anti-diabetic drug, metformin and insulin therapy. So friends, as we know, this metformin or insulin, we have to start when GDM is not controlled by MNT. So insulin is the first drug of choice, and metformin can be considered after 20 weeks of gestation for medical management of GDM. Here I want to emphasize, because we are having some patients of obese PCOS who are conceived with metformin. In that patient, now all the studies have come that metformin is pretty safe in the pregnancy. So insulin can be started at any time during pregnancy for GDM management if the woman blood sugar is not controlled, with the maximum dose of metformin 2 grams per day and MNT insulin to be added. So friends, as we know, metformin is available in so many forms, so many type of preparation, 500 mg, or sometimes we are giving the sustained release preparations, also 500 or 1000 mg. So the dose will be 500 mg twice daily, or maximum up to 2 grams per day we can give. But with metformin, the side effects are very commonly reported. So in this, like this hypoglycemia, weight gain with the metformin are less in compared to the insulin. The commonest side effect with metformin, yes, most of the patients complain of nausea, diarrhea, stomach pain, heartburn, gas, and the serious side effects such as lactic acidosis and the low blood sugar has also been reported. So now coming to the insulin therapy. Friends, whenever I take this talk for this diabetes mellitus, so many doctors ask me that how to calculate the dose of the insulin. So friends, as I just mentioned, please, managing this is a multidisciplinary approach. I always take the opinion of the physician or the endocrinologist or the diabetologist for regarding the dose of the insulin. So Actrapid or mixed-start insulin can be given in pregnancy. In a simplified form, the dose requirement can be decided as follows. In the first trimester, 0.7 unit per kg, while in the second trimester, 0.8 unit per kg, in the third trimester, 0.9 unit per kg, while in the term 1 unit per kg. If difficulty in calculation, we can start with 4 units 3 times daily of extrapid insulin and then titrate twice a week and adjust the dose. Mixed-start insulin, 30% rapid-acting insulin and 70% of isofen insulin, and 2/3 dose has been given in the morning with breakfast and 1/3 at night with dinner. So this is a very crowded slide. So how to calculate this blood sugar? So as we just discussed, always take the opinion of the diabetologist also. If we are starting the premix insulin 30/70, that has to be given subcut 30 minutes before breakfast once a day. And dose has to be titrated depending on the blood sugar levels. If the blood sugar 120 to 160, then 4 units, 160 to 200, 6 units, more than 200, 8 units. Actually, managed so many patients with the diabetes at the time of my residency. So this chart was एकदम हम लोग को याद रहता था कि how to increase this insulin level and how much to increase before we take show the reports to our seniors that how much we have to increase. So now 2 hours of this APP blood sugar is less than 120, then we have to continue this MNT and physical exercise. Now coming, so how to increase this dose? So as I earlier mentioned in the slide, the blood sugar and fasting and PP, we have to monitor every 3rd day till the insulin dose is adjusted. So if it is not controlled, if after the postparental is coming is still high, then we have to add 2 units pre-breakfast if still the PPBS is raised, and true, if the fasting blood sugar is also coming high, then we have to add more 2 units pre-dinner. So coming next. Again, I am emphasizing the point. So friends, never try to manage alone. Please take a help of our the diabetologist colleague, the physician colleague is much better. So as we know, the hypoglycemia is a very common complication. All the pregnant women on insulin can develop hypoglycemia at any time. Diagnosed when blood sugar level is less than 70 mg per dl. Now, how to recognize hypoglycemia? The early symptoms: the tremor of hand, sweating, palpitation, hunger, easy fatigability, headache, mood changes, irritability, low attentiveness, tingling sensation around the mouth, lips, or any other abnormal feeling. If it is severe, then confusion, abnormal behavior, or both, visual disturbances, nervousness, or anxiety has been reported, and seizures and loss of consciousness, though very uncommon, but has been reported. So now how we have to manage this hypoglycemia? Yes, we have to tell the patient to take a 3 TSF of the glucose powder dissolved in a glass of water. If it is not available, then she can take the sugar 6 TSF or some fruit juice or honey. And after taking this, she has to take rest and avoid any physical activity. And she must take 1 chapati with vegetable, rice, glass of milk, or idli or fruits or anything eatable what is available. If the pregnant woman develops more than 1 episode of hypoglycemia in a day, then she has to consult the doctor immediately. Well, suppose if the patient calling us that she is having hypoglycemia, initially the first treatment we have to advise this. Actually, in my practice, whenever we are treating this gestational diabetes mellitus patient, all these instructions we already mentioned in the paper of the file of the patient, that if she is suffering from the hypoglycemia, what she has to start. So now what are the special obstetric care for pregnant women with GDM? What are the guidelines from our FOXI has been suggested? The antenatal care in cases diagnosed before 20 weeks of pregnancy, a fetal anatomical survey by USG should be performed at 18 to 20 weeks. For all pregnancies with GDM, a fetal growth scan should be performed at 28 to 30 weeks gestation and repeated at 34 to 36 weeks. There should be at least a 3 weeks gap between the two ultrasound, and it should include the fetal biometry and amniotic fluid estimation. Now, what are the fetal surveillance in pregnant women with GDM? So friends, as we have just discussed, the pregnant women with GDM are at an increased risk for fetal death in utero, and there is an increased risk of increase in pregnant women requiring the medical management. Hence, vigilant fetal surveillance is required. Fetal heart should be monitored by auscultation. Yes, we are either by the auscultation or by the fetal Doppler. We are doing this, and so the mom can also listen the fetal heartbeat sound, and so she feel happy. So pregnant women should be explained about the daily fetal activity. One simple method to tell her to lie down on her side after a meal and note how long it takes for the fetus to kick 10 times. If the fetus does not kick 3 times within 1 hour or a minimum of 1 time in 1 hour, she should consult her doctor. So continuing what are the guidelines we are following at the time of the labor and delivery? So at the timing of the delivery, the GDM pregnancy is, as we all know, associated with the delay in the lung maturity of the fetus. So routine delivery prior to 39 weeks is not recommended. If the pregnant woman with GDM is with well-controlled blood sugar delivered spontaneously, induction of labor should be scheduled. In the pregnant woman with GDM with poor blood sugar control, those at the risk factors like hypertensive disorders or pregnancies, previous stillbirth or other complications should be delivered earlier. The vaginal delivery should be preferred, and LSCA should be done for obstetric indications only. In case of fetal macrosomia, the estimated fetal weight more than 4 kg, consideration should be given for an elective cesarean section at 39 weeks to avoid shoulder dystocia. So now, what are the special precautions we have to follow at the time of the labor? So friends, as we know, the pregnant women with GDM on the medical management, either with the metformin or insulin, requires a blood sugar monitoring during labor by a glucometer. The morning dose of insulin metformin is withheld on the day of the induction labor, and the pregnant women should be started on 2 hourly monitoring of blood sugar, infusion with normal saline to be started, and regular insulin to be added. So now, this is a very beautiful table. We can see how much the rate of the normal saline infusion. If the blood sugar is 90 to 120, then it's 100 ml per hour, 16 drops per minute. If 120 to 140, then 4 units insulin. And 140 to 180, then 6 units. And more than 180, then 8 units. Means 16 drops per minute we have to give this. And all the neonates should be received immediately the essential newborn care with emphasis on early breastfeeding to prevent hypoglycemia. It's such a big topic now. As much as possible, I am trying to include today. So post-delivery follow-up of a pregnant woman with GDM. Immediate postpartum care of women with GDM is not different from the women without GDM, but these women are at high risk to develop type 2 diabetes mellitus in future. Maternal glucose levels usually return to normal after the delivery. Subsequently, 75 gram OGTT at 6 weeks postpartum to evaluate the glycemic status of women. Very important. And as we know, the pregnant women with GDM and their offspring are at an increased risk of developing type 2 diabetes mellitus later life, and that they should be counseled for healthy lifestyle and behavior, particularly the role of diet and exercise. So friends, this is very, very important. If we are delivering the diabetic patient or the gestational diabetic mother, we have to give the instructions that they have to come in the 6 weeks when we are calling for the postpartum. At that time, we have to do her blood sugar, fasting and PP to know the status. So now what are the updated ACOG guidelines for this? So ACOG has released the updated guidance of gestational diabetes mellitus, which has becoming increasingly prevalent worldwide. Class A1 GDM refers to diet control, while class A2 refers to the clinical scenario where medications are required. So these things I have already discussed. I'm not repeating this. So according to this ACOG guidelines, considering the early pregnancy, if the patient is overweight with the BMI of 25, and one of the following: the physical inactivity, known impaired glucose metabolism, previous pregnancy history of GDM, macrosomia or stillbirth, hypertension, HDL less than 35, and fasting triglycerides more than 250, or there is a history of PCOS or non-alcoholic steatohepatitis or morbid obesity, or the HbA1c more than 5.7%, or any cardiovascular disease, or a family history of diabetes, ethnicity of African, American, Indian, Hispanic has been reported more. So this, according to this ACOG guidelines, screening for diabetes and pre-diabetes in the postpartum period, ACOG has now suggested the screening women who had the GDM between 4 and 12 weeks postpartum for diabetes and pre-diabetes. Then what are the glucose target levels? So ACOG and AD recommend the following target levels to reduce the risk of macrosomia. So fasting and pre-parental blood glucose values less than 95 mg per dl, and post-parental less than 140 mg per dl at 1 hour and less than 120 mg per dl at 2 hours has been reported. So now, what are the role of this diet and exercise? So as we all know, we have just discussed that we have to recommend the complex carbohydrates, the 3 meals, 2 snacks to limit the glucose fluctuation, ideal caloric distribution between the carbohydrates, fat and protein, 30 minutes of moderate intensity aerobic exercise at least 5 days a week, or minimum 150 minutes per week. Improvement seen while walking 10 to 15 minutes after each meal. That is also very, very important. So according to this American college, what are the guidelines have suggested the insulin be the preferred therapy if glycemic control is not obtained with the non-pharmacologic treatment. Substantial number of the patients started on oral therapy will require the insulin during pregnancy. The starting dose of insulin is 0.7 to 1 unit per kg daily. Dosage should be divided, and long-acting and intermediate-acting insulin in combination with short-acting insulin should be used. We have to individualize based on the patient's glycemic pattern, and the short-acting analogs preferred over the regular insulin due to more rapid onset. NPH still used for, but insulin glargine and detimir available for the long-acting coverage. So friends, I never decide this. I always take the opinion of the physician, and according to them, we start either the insulin glargine or detimir. So the pharmacological guidelines, if the patient cannot take insulin or declines, the metformin can be used. We have to counsel the patient that metformin crosses the placenta, but no long-term studies. Now, so many studies, so many papers have come that it is absolutely safe. The dose has been recommended Earlier, some studies all have said up to the 2 gram. Now there are some studies have come up to the use of 2500 to 3000 mg per day in 2 to 3 divided doses. Adverse side effects we know is the abdominal pain and diarrhea. Other drug means the glyburide should not be used in place of insulin, and studies have shown the worst outcome like the macrosomia and birth injury. So the starting dose of that is 2.5 to 20 mg, but we prefer the insulin or the metformin. So better I'm not taking this. So fetal monitoring, according to ACOG guidelines, that on medication, patient is with A2 GDM with poor control and without comorbidities 32 weeks. We have to begin earlier if the other comorbidities are present. Fetal assessment for A2 GDM in general is usually recommended based on the understanding as there may have been poor control at some point during the pregnancy. Well controlled on diet. No consensus due to lack of the data. Fetal assessment may not be necessary. If performed, usually begin later, then A2 GDM can be based on local practice. Include the amniotic fluid volume assessment due to risk of polyhydramnios. So now when to deliver, if the patient is controlled on diet more than 39 weeks, expectant management up to 40 weeks, 6 days is appropriate with antepartum testing. Well, guidelines have suggested well control on medication deliver at 39 weeks and poorly controlled is 37 weeks, 0 days to 38 weeks, 6 days may be justified. Delivery in between 34 weeks to 36 weeks reserved with the failure in hospital to glycemic control and abnormal fetal testing. Estimated fetal weight more than 4,500 counsel regarding the risk and benefits of a scheduled cesarean section. So friends, these are the ACOG guidelines, but practically in my practice, I am delivering them in 36 weeks plus. So now what are the NICE guidelines have come from 2020? I know this is a very lengthy lecture. The NICE guidelines now recommend the offering the continuous blood glucose monitoring to all pregnant women with type 1 diabetes to help them to meet their pregnancy blood glucose targets and improve the neonatal outcome. So the studies have shown from the Swedish also have come that that all have shown that CGM is used for the continuous blood glucose monitoring resulted in more women achieving their blood glucose targets, fewer cesarean section and fewer neonatal intensive care admissions. They concluded that with high quality evidence and that CGM was associated with better clinical outcomes and 94% chance of CGM of being cheaper than capillary blood glucose testing. So take the next here. So according to these guidelines, the females, we have to see this third one. So the nationwide implementation of the postnatal HbA1c measurements at 3 to 6 months in conjunction with infant vaccination instead of an addition of fasting blood glucose 6 to 12 weeks may be further improve the postnatal GDM care. So friends, it is very important whenever we are following the patients for the follow-up and that time also the checking of the blood sugar and HbA1c is also very important. So according to this NICE guidelines, so to examine the effectiveness and acceptability of insulin pump therapy and continuous glucose monitoring used in the women with diabetes who are planning pregnancy. So among this, to explore the barrier of achieving pregnancy and glucose targets in women with gestational and pre-gestational diabetes. And we have to investigate the pharmacologic interventions which may delay or prevent the type 2 diabetes developing in the woman with gestational diabetes. So the guidelines have suggested the pregnant women with type 2 diabetes and HbA1c more than 6.5% have, by definition, unstable blood glucose level and increased risk of stillbirth, because of what we obstetrician are very much worried in the GDM patients for the sudden stillbirth, sudden IUDs, stillbirth and neonatal deaths. With the use of the continuous glucose monitoring or flash should be considered for all women in this category. So yeah. So these are the guidelines from the NICE. So the guidelines have suggested, we have to see, in addition to interventions for delaying and preventing the type 2 diabetes, more work is needed to optimize the immediate postnatal and annual glucose surveillance in all women with a previous pregnancy complicated by the GDM. So again, in the nutshell, I am revising this. So screening, as we have just discussed, whenever the patient visits us first, that is very important. Otherwise, if the patient, the regular follow-up, again, the screening in between 24 to 28 weeks is very important. And we are usually following the 75 gram OGTT, in which the fasting 1 hour and 2 hour blood sugar we are doing. Friends, if you want to go for these data, this data is very recent, of the 2021 only. You can take from www.diabeteset.net. You can get all these details over that. All these beautiful tables are in that. So studies have shown this. This is also from the very recent, from the issue 2021. The female with hypothyroidism were more likely to suffer from gestational diabetes, hypertensive disorders, and gestational hypertension and preeclampsia. So this there is an association between smoking and GDM. Again, it is supported from the ISHRA studies. The females who smoke during pregnancy are having a more risk of developing this GDM. These all are the recent studies at what I have taken. So yes, now the question is coming. Yes, is the HbA1c measurement is very important. Yes, the HbA1c measurement is an indicator of the blood glucose control in prior 3 to 4 months, and may be avenue of earlier identification of the woman at a risk of GDM. So it has been suggested that to maintain the HbA1c in the pregnancy should be less than 6%, and it can be achieved without any significant hypoglycemia. So it is very, very important to do this HbA1c too. So studies have again have come that the metformin is not recommended for the prevention of GDM with PCOS and infertility who become pregnant while taking metformin. So the studies have come that metformin, the role of the metformin seems to reduce the risk of the fetal loss during the first trimester. As you've seen, a lot of patients have gone for this early pregnancy losses in this GDM too. Yeah. So we have to control by the diet and some supplements also. The goal of the therapy to be achieved by controlling caloric intake, tailored to maternal and neonatal needs, avoiding the long fasting. It is to recommend to receive 20% of calorie intake from proteins, 50% from carbohydrates, and 30% from fats with a proper distribution. So, coming to this, yes, here it is again just a very important slide I can take in a nutshell of this. Yeah. So in GDM patients, the caloric intake should be 50% of carbohydrate, 30% of fat, and 20% of protein. The diet should be include at least 3 units of low-fat dairy and use of more units depending on the energy requirements of the individual. For here, the intake of the fiber is very, very important. For each 1000 calorie intake, 14 gram of fiber should be received, including 5 units from vegetables, 4 units from fruits, and 1 unit from the cereals. So this is very, very important. And the simple sugars can account up to the 10% of caloric intake. However, it is more favorable to limit the intake of simple sugars to 5% of the caloric intake. So yes, exercise, role of the exercise. Yes, of course, the moderate intensity training is recommended for at least 30 minutes daily, 4 to 5 days a week is very, very important. Women without physical fitness should start physical activity at low intensity, 15 minutes daily, and gradually increase the duration of training. So what are the goals of the therapy to control the blood glucose in GDM? So the goal of therapy after 24 weeks of gestation is to reach the fasting blood glucose less than 95 mg per dl 1 hour, and PPG less than 140, and 2 hours less than 120. So it's very important. It's again, I'm summarizing the fasting plasma glucose level less than 95, and 1 hour less than 140, and 2 hours less than 120. It's very, very important. So again, a very, very important query regarding the role of the glucocorticoids to improve the fetal lung maturation in GDM. So the glucocorticoids can be used for GDM women to improve the lung maturation if premature delivery is suspected or determined. Yes. So the studies have shown that the women with GDM acceptable and glycemic control without insulin therapy, warning about the risk of hyperglycemia and close monitoring of blood glucose is advisable, and if glucocorticoid would be prescribed. So now, what are the guidelines have suggested for the screening of GDM at the COVID time? This is also very, very important in this evolving pandemic with a highly infectious virus and the screening. OGTT involves the high exposure risk and health service burden. The routine use of OGTT for GDM screening needs to be carefully considered in the context for the local pandemic impact. So we have to do this HbA1c and random plasma glucose level primarily to detect over diabetes. If patient is not able to come for the follow-up due to COVID, then at least whenever the patient is coming, the HbA1c and this plasma blood glucose level is very, very important. We have to monitor for the complications of any GDM that have missed in the routine care, and real time for the evaluation and impact of pandemic screening and strategy implication is very important again. So friends, now what are the changes we have done in 8 to 14 weeks gestation? Whenever the patient is coming, coincide with the booking visit blood test. At that time only we are advising this HbA1c and random plasma glucose level. If it is HbA1c more than 6 and random blood sugar is more than 200, then it is considered to be over diabetes in the pregnancy. If it is HbA1c is 5.9 to 6.4 and blood sugar is 162 to 200, then early GDM. So if it is coming normal, then when we have to take the follow-up, in the follow-up the 28 weeks, then we have to check again the HbA1c and the plasma random plasma glucose levels. If this is coming again more than 162 and HbA1c more than 5.7, then it is considered to be the GDM. But if the HbA1c is coming less than 5.7, and then it is not considered under the category of the GDM. So a very important point in these patients, once we are calling at 8 to 14 weeks at that time also we have to advise the blood sugar and the HbA1c too. So this I think again a very, very crowded slide to how to manage this. So for this, as what we have just discussed now, again I am giving emphasis, the focus on the point that it is a multidisciplinary approach. So we have to include our other colleagues too. So now the studies have come. This study have come. In fact, I am using most of the patients inositol supplementation in the prevention of the gestational diabetes mellitus, because the studies have shown the cumbersome administration, the method, and high chance of side effects like hypoglycemia, weight gain with the insulin. But with this, in contrast to this, the minoxidil supplementation is very safe, which reduces the risk of GDM among the obese and overweight pregnant women, as well as the women with PCOS with a family history of type 2 diabetes mellitus, because inositol is considered to be safe and having a very good results. So studies have shown for this this oral supplementation of the minoxidil with a dose 1 gram BD started as soon as the diagnosis of GDM is effective in achieving the glycemic control and decreasing the need of additional pharmacologic therapy in Asian women. The study has been presented in this February 18, 2021 only. So friends, usually for PCOS, we are recommending the 4 gram per day, but for here we are giving the oral supplementation of minoxidil 1 gram BD we are giving. So, or otherwise the 2 gram oral minoxidil started as soon as the diagnosis of GDM has been made. And we all know that it is very safe in the pregnancy and lactation too. So again, the studies have been come from this Angelica, and the studies have shown the minoxidil, due to its insulin mimetic qualities, activates the GLUT translocation to the plasma membrane and then leads to an increase of glucose transport through GLUT4 into the cells. According to these theories, minoxidil could reduce the insulin resistance in the pregnancy, and minoxidil supplementation could increase the action of the endogenous insulin. So a lot of studies have come, the use of this minoxidil. This is again a very recent studies published in 23rd April 2021 only from the Rosaria and Francisco. The studies have shown the combination of minoxidil and alpha-lactalbumin may reduce the insulin resistance and excessive fetal growth in women with GDM. Furthermore, a reduced rate of insulin treatment and preterm birth was demonstrated in the treated group. The studies have shown a very, very good results. Apart from studies I am using in so many of my patients, they are getting a very, very good results. And as we all know, there are a lot of preparations are available with this minoxidil along with the folic acids. Yeah. So, so it is very safe to give. It reduces the risk of just a second. Yeah. So along this, we are giving this minoxidil along with the combination of vitamin D3 and folic acid too. So as we know, so this all help. This minoxidil increases the level of adenopectin level by 28%, and we also know the role of vitamin D3. It decreases the fasting glucose and improves the insulin sensitivity and beta cell function. So now coming to the conclusion. So gestational diabetes mellitus can be easily controlled by diet and exercise, and it can be treated with oral metformin tablet as they do not harm the fetus. Insulin injections are required during the pregnancy. Most of the patients we will stop the insulin post-delivery. Injecting insulin over the abdomen is also 100% safe. Modification of the diet is easy. Sweet should be avoided at all the times during pregnancy. If the blood sugar is controlled, the patient and her baby both are safe and healthy. And pregnant women with GDM should deliver at health facilities. It will help in management of any complications which can be countered during delivery. So friends, as all we know, this is a very, very vast topic. So I tried to cover as much as possible. So some of my friends have joined later on. So as we all know, this is the PCOS Awareness Month September. So I will invite all of you, please do join with me for the interactive sessions for this pregnancy in PCOS on the 10th September and PCOS nutrition on the 17th September. Besides that, I am getting a lot of requests for regarding this masterclass. So we have started the series of this masterclass for this aesthetic gynecology on the 19th September we are doing, which has been endorsed by ASFMS MAM and Buzz Society of Cosmetic Gynecology. I have posted the details on all the social media. Those who are interested can join that. And 8th and 9th October, we are having this masterclass of sexual medicine. So those who are interested, that will be a unique kind of masterclass, which is which will clear all your doubts what in the practice we are getting. So with this, I would like to thank to all of you and thank you for your interest and your time. And thanks to Shield Connect also for inviting me here.
Thank you very much, ma'am, for the wonderful talk.
Huh.
We are very honored to have you, ma'am. And
Thank you.
and
If any questions,
yes, ma'am. There are questions. I'm just dropping in the chat box.
okay. I will just, yeah. Yeah, hi, Dr. Sudhamani. Yeah, Dr. Sudhamani is asking how you treat polyhydramnios, which is very, very common as GDM patients. Yes, Dr. Sudhamani, that is very correct. Yes, very, very common polyhydramnios. Usually, if you control properly, so yes, in some patients, I emphasize so many times, I always take the opinion of this endocrinologist and physician. Sometimes we are titrating the dose of the insulin and getting control, and then sometimes, of course, it is too much of the polyhydramnios that we have to tap also. So it is a multidisciplinary approach, so we have to take, but and indomethacin I'm not using. Yes, though the studies have been reported for that, but I have no experience with the use of this indomethacin. Is anyone of have the experience with the use of this indomethacin? So let me know for this, the treatment for this polyhydramnios. Is it any more questions? Yeah. Yes, inositols as an adjuvant in the medical, and yes, for the lifestyle modification. See, basically this inositols are what? It's a group B complex vitamin. So we can give to the B complex vitamin because most of the patients is everyone is now so much of this health conscious. So yes, we can give this B complex vitamin myoinositols, we can give because that is already having a lot of benefits, especially in the PCOS patients. So once we start, they take for 3 hours. Sorry, they take for 3 months, 6 months. And of course, if the patient get the benefit, they can continue also. Yeah. Hi, Uma. Uma, I have already shown that all details in my presentation, how to manage that HbA1c. The slides will be uploaded on this in their Shield Connect page. You can go and see. Checking 1 minute. Yeah, Dr. Shubhi Naqvi is asking at what time the blood sugar level will be checked for the, at what time? Yes, I have, Dr. Naqvi, I think you have joined late. See, what mentioned according to this Indian scenario, because हमारे पास क्या होता है, patient कभी-कभी proper follow-up में नहीं आता बाद में. So whenever the patient approaches to you, you have to do this blood sugar level. अगर proper उस time पर नहीं आया तो आप random भी कर सकते हो. Otherwise, what the guidelines have suggested, in between the 24 to 28 weeks, you have to do the fasting also and postprandial also. OGTT. Yeah.
There are no more questions from the delegates.
Okay.
Yeah, thank you very much, ma'am, for the wonderful talk and for your valuable time. And we look forward for your continuous support for the upcoming webinars as well. Thank you very much, ma'am.
Sure. Thank you. Bye-bye. Good night.
Thanks from the Shield, and I also thank all the delegates for their patient listening and for taking your valuable time. Thank you very much and have a good day.
Yeah. Bye-bye.